Good morning, ladies and gentlemen. Thank you very much indeed for the invitation. I'm delighted to accept, as often peripheral arterial disease is not part of the core curriculum, so it's great to have a captive audience of cardiologists to talk to. These are my disclosures. And first of all, let's talk about peripheral vascular disease. Now, a lot of people use the term peripheral vascular disease when they really mean peripheral arterial disease. And as a vascular physician, I see carotid disease, aortic disease, upper limb, lower limb, small vessel venous, and lymphatic disease. What I'd like to talk to you about today is peripheral arterial disease. To just be slightly more confusing, in the UK, we refer to atherosclerosis in the lower limb as peripheral arterial disease. The Americans have decided that they should call it peripheral artery disease to match coronary artery disease, and the European Society of Cardiology have just gone out in a limb, excuse the pun, to call it lower extremity arterial disease. Now, I tell you that because if you're interested enough to do a literature search about peripheral arterial disease, you have to use all three terms now. And obviously I want to talk about peripheral arterial disease. I'd like to go through all 5 of these areas: epidemiology, presentation, diagnosis, management, and prognosis. So let's look first at the epidemiology. It's a very, very common disease. It affects 20 million adults in the EU, and it's estimated that by 2027 it will affect 27 million, because of course it is a disease of the elderly, and we have an increasingly elderly population. Here's a study from way back in 2000. They took 10 very, very large studies across Europe, and you can see how it increases with age. And in fact, the study stopped at 74, but if you go up here, you're getting a prevalence of up to 15 and sometimes 20%. So as our population ages, we're going to see more and more of this disease. So what are the risk factors for peripheral arterial disease? Well, these look unsurprisingly very familiar. The same risk factors that you see for coronary disease. And the only difference really is that diabetes and smoking is perhaps more relevant for peripheral arterial disease for reasons that we can discuss. Here you can see a patient with diabetes, and of course one of the problems is the peripheral neuropathy. They don't feel when they injure themselves, and they end up with a very bad lesion. If you look at people who have type 2 diabetes, after 2 years, 15% will have peripheral arterial disease, and if they last to 20 years, almost a half of your patients will have peripheral arterial disease. And unfortunately, it's a bad disease to get because it's in the small vessels, and the majority of amputation takes place in patients with diabetes. The next risk factor which you really have to consider is smoking. And in fact, if somebody who's got peripheral arterial disease tells you that they have never smoked, then you really have to question their veracity, because it is very strongly linked. And you must remember that the patients that you're seeing now with peripheral arterial disease were teenagers in the 50s and 60s. And here's an advert from the 50s, and you can see that if people want to be like doctors, they used to be, and of course this was a really strong advert for them. Here's an advert from the swinging 60s, and you can see a nice low-cut dress here and a surefire way of getting the girl. And then finally, in the mid-60s, when it began to be publicly aware that there were some problems with your health and cigarette smoking, they said, well, what the heck, have a fag. You could get run over by a bus. So, in fact, you mustn't blame your patients, because this is a type of advertising that they were subjected to when they were very vulnerable. And of course, you can encourage them to stop smoking, and here you can see smokers continuing to smoke and smokers who've given up, and the development of critical limb ischemia is attenuated. So giving up is definitely good. And of course the pathology is the same as coronary disease. This is indistinguishable, atheroma, and we have critical limb ischemia and intermittent claudication are the two terms. The vast majority of patients have intermittent claudication, and this is essentially just angina of the legs. You have a stenosis and you walk and you get pain. And depending on where the stenosis is, you can get it in your foot, commonly in your calf, in your thigh, and also in your buttock. And it's a standard angina of the legs. Unlike the heart, you can actually physically examine the leg, and although you don't get pain in the muscles until you walk, there are signs of diminished nutrition, cool skin, loss of hair, etc., poor pulses, and sometimes you can hear a vascular bruit. The more serious form doesn't occur very often, thank goodness, and you can see here the chronic form, which has come from intermittent claudication, and you can see these toes are just dying on the end of this person's foot. Or it can be acute, and acute is usually embolic. We have much less plaque rupture causing acute limb ischemia because the vessels are bigger, but you get sludge from the aorta or you get an embolus from AF and things like that. And similarly, you have particular symptoms, and the classic one is pain at rest. Now, you can imagine, if this toe was yours and it's dying at the end of your foot, the pain is excruciating. And one of the big problems we have is persuading people that this pain is as bad as terminal cancer and needs to be managed aggressively. It's worse at night, and the patients like to sit with their leg hanging down to get the blood there. When you look at the patients, similar to claudication, cool, tissue nutrition, if you lift the leg up, the blood drains and the foot becomes white. Peripheral pulses have gone, ulceration and gangrene. Very nice and easy to spot. Now, we talk a lot about peripheral pulses and we encourage people to do them, and here they are being demonstrated. But the problem is, if you are not measuring these pulses every day, very large studies have shown that in only 1/3 of cases are you correct. It's partly due to poor technique, but also the legs are often swollen, you can feel your own pulse, and interestingly, because of anatomical variation, they're sometimes not where they should be. So peripheral pulses are not very useful, and I'll go on later to tell you what the best test is. For those of you who may want to do some research, we don't just use those two clinical terms, but we actually use classifications. You can see here is the Fontaine, which is a European, Rutherford, which is American, and it goes through claudication at over 200 meters, under 200 meters, rest, pain, and gangrene. Rutherford is very similar. It just has this minor tissue loss, and that's quite useful because by the time you get to gangrene, no medical treatment is going to get it better. And so this is quite useful when you're doing clinical trials because these are not no-hope legs. But unless you're doing research, you don't have to use those classifications. So how do we investigate peripheral arterial disease? Well, the best diagnostic tool we have is the ankle brachial pressure index. And like you in cardiology, we use duplex arteriography and MRA. And in fact, the pictures now for MRA are so good, carotid, renal, aortic, that right down to the foot, that we very, very rarely do angiography, even pre-surgery. Our duplex scans and MRA are so good. But to make the diagnosis, you want to do the ankle brachial pressure index, you want to measure the arm blood pressure and divide it into the ankle pressure, and that will give you a ratio between 1 and 1.3. If it goes down, it's abnormal, and below 0.9, we say this confirms peripheral arterial disease because it gives you a 90% sensitivity to detect a 50% stenosis in one of the major vessels. So we use 0.9 as our cutoff. It's very sensitive, more sensitive than FOB in picking up cancer, more sensitive than cervical screening and mammography. The only catch is with diabetes, when you can get calcification and stiffening in the vessels, they don't compress, in which case you do a toe blood pressure. How do we treat claudication? 5 things there, let's look at them. First of all, exercise. Exercise is actually very efficient. onset of pain, and then you walk through the pain and get to maximal pain. And you can see that the distance increases as you exercise the patient. But here's the problem. If you look at what gives you a significant benefit, you've got to do it for longer than 30 minutes, more than 3 times a week, for longer than 26 weeks. And you have to walk through pain to near maximal pain. And any combination, it doesn't work. It has to be walking. Now, I don't know how many of you have a walking class for your patients with peripheral arterial disease, but I don't. I send them to cardiac rehab, even though the evidence suggests that it's not going to be beneficial. And of course, the big problem is that only 10% of patients will comply to such a strict exercise regime. So very effective, but only in 10% of your population. So what about drug therapy? Well, in the UK, there's only one drug registered, that is cilostazol. In Europe, you also have naftidrafural, otherwise known as praxilene. And the problem is that although they are giving statistically significant results, as you can see here, compared to what I think is a placebo, pentoxifylline, only registered in the United States, unfortunately, the statistics don't bear out in terms of distance, and the maximum improvement you get is possibly about 150 to 200 meters. Now that's great if you're a bus stop. If you can walk 200 meters and your bus stop's 300, you get there. But actually, in the greater scheme of things, it's not a tremendous improvement. So we tend to try it. If it doesn't work after 3 months, we stop it. So what about surgery and angioplasty? Angioplasty is very effective, as you can see here, very nice results. But surgery is really hardly ever used for claudication, and the reason is, as you can see here, there is a failure rate for grafts. And what you can do is you can change somebody who's claudicating at, say, 200 meters into somebody who has a block graft and then an amputation. So you have to be a very brave surgeon to operate on people with claudication. In contrast, critical limb ischemia is a clinical emergency, and endovascular treatment is the treatment of choice. And we use surgery, we use angioplasty, and we use local clot removal and thrombolysis. And the big aim, of course, is to reduce amputation. And these figures are from the 1980s, and you can see pretty awful response, particularly for above knee. A third of your patients are bed rest. This reference here, 2016, shows almost identical figures. These are old people. They really can't mobilize well with prosthesis. And the only difference is that instead of 30%, it's 28% and 50% in a wheelchair. So absolutely abysmal rehab for these folk because they have bad hips, bad spine, and they just can't use a prosthesis. So we want to avoid it at all costs. So what about the big thing, the modifying cardiovascular risk? Well, for many years, people really ignored this. They said, look, here's your outcome for your patients. Hardly anybody gets to amputation, and some may deteriorate, but actually it's a fairly benign disease. And if you look at the 100 patients diagnosed with claudication, you really have a very good outcome. But for every 100 patients who are diagnosed with claudication, you've got 100 folk who are saying, oh, it's my back, oh, I'm getting old, it's my hips, I'm stiff, my legs sore. They don't go to a doctor. And you also have another 100 patients who are asymptomatic, mainly diabetic patients with their peripheral neuropathy. And the problem is that it's not the claudication that's the problem, it's the attrition that you see with your myocardial infarction and your deaths. So these patients really have a very poor outcome. Here we have Michael Creaky's seminal San Diego study published in the 90s, and you can see at 5 years, 25% are dead, and at 10 years, 50%, no matter whether it's asymptomatic, intermittent claudication, or CLI. And you say, yeah, but that was then. So here you have a publication from just over a year ago, and what you can see is that at 5 years, the death rate is 25%, and at 10 years, it's 50%. And that's not just because people weren't being treated. This is a huge burden of atheroma, because by the time you get symptoms, your vessels are almost clogged, because these are big vessels, and therefore your burden of atheroma is huge. And this is to just give comparison. And if you said to a female, would you rather have breast cancer than pain in your legs? I bet you they would say pain in the legs. And the same with prostates, the same percentage. If you asked a guy, he'd probably say, oh, I'd rather have pain in the legs. And in fact, it equates exactly to Duke stage B carcinoma of colon. And if you look at these figures for coronary disease, and this is 6-year mortality, not 5-year, it's double for PAD. So in fact, you lot have done a lot of good for CAD, but we're losing out for PAD. And of course, it's mainly coronary disease and stroke that kills our patients. And as I've said, these vessels are big, you're a huge burden, and you may just have isolated coronary disease, but actually when you've got PAD, 60% will have clinical evidence of disease elsewhere, and if you do an angiogram, they'll all have heart disease. So if you've got PAD, you've got 2 to 3 times more commonly have stroke, 4 times fetal MI, and 6 times a death from cardiovascular disease. So when you see someone with PAD, you really have to think somebody with heart disease. So what happens if we do modify risk? Well, good things happen. Here you can see all risk factors control 1 to 4 and none, and you can see decreasing events as you improve risk factor management. Now, there are a number of guidelines for peripheral arterial disease. The European Society of Cardiology and the European Society of Vascular Surgeons got together a few years ago and wrote a very good guideline. But this is a more recent one. The risk factor chapter was published in September, and the whole guideline was published in December. And it stresses the importance, obviously, of smoking and, as you would expect, statin therapy. What's the evidence for statin therapy? Interestingly, it's only really the heart protection study subgroup analysis where you can see folk with PAD benefited just as well. What was ignored, however, was the 4S study, where they actually showed that the development of claudication was inhibited by simvastatin. So in fact, here you have the first evidence that statins are beneficial to the actual limb, not just in preventing the cardiovascular events. But it wasn't really until the REACH registry, with many 38,000 patients, where you actually began to see the benefits of statins on the limb in terms of limb outcomes like angioplasty, surgery, and amputation. And more recently, as you would expect, this has been shown to be dose dependent, and the higher the dose of statin, the lower your amputation risk and, of course, your mortality. What about symptoms? Because we have very little. Well, it's very interesting. There have been 4 or 5 studies that have actually shown an improvement in walking distance with statins. However, these weren't followed up because it became unethical to have a placebo group, but it's tantalizing. And here's another study that, again, would not be ethical to do now, showing that if you're statins, your graft patency improves. And so for that reason, we must treat these patients with statins if tolerated. And this is the recommendation, very similar to the European Society of Cardiology in terms of recommended levels. If it doesn't work with statin, add in ezetimibe, and if that doesn't work, then the PCSK9 inhibitor. And I'm sure you're aware of the Fourier study, which is where this recommendation comes from. Here it is, your major cardiovascular events split for peripheral arterial disease and no peripheral arterial disease. And you can see that a lot of the effect in the Fourier study comes from treating these very severely atherosclerotic patients. And of course, it wasn't just a good effect in the heart, but it was also a very good effect in the limb, again, with decreased acute critical limb ischemia, interventions, and amputation. Now, having a wee look at the Fourier study in terms of its placebo group, you will remember that all these patients were on fairly intensive statin therapy. And despite this, in PAD, you had a 13% attrition rate in the placebo group, as I say, double what you get with cardiac disease. And even with the PCSK9 inhibitors, you still had 10%. So there's something else, there's still some residual risk. So what about platelets? Well, here you can see old study, antithrombotic trialist collaboration, showing benefit from antiplatelet agents in peripheral arterial disease. But what people don't realise is that all but 2 of the studies in peripheral arterial disease were in ticlopidine. And actually, aspirin is not a component of the PAD study, and people say antithrombotic and they actually translate that in their head to aspirin. And in fact, we now know that aspirin really doesn't work for peripheral arterial disease. And there's a number of studies, and rather immodestly, I have chosen to show you my study, where you can see absolutely no benefit over 8 years from aspirin. So what antiplatelet does work? Well, here's a Capri study with clopidogrel, and you remember that everybody was rather unimpressed with this slight risk reduction. But what the company at the time wasn't terribly keen to show was that the vast majority of the benefit was in patients with peripheral arterial disease, but they were trying to market clopidogrel to patients with myocardial infarction, and so this didn't become well known. However, we do know now that clopidogrel is the antiplatelet agent of choice, up until, of course, the COMPASS study. And then things became a wee bit more confused. And again, you're familiar with the COMPASS study, I'm sure, where you have the 2.5 milligrams twice a day of rivaroxaban, aspirin, rivaroxaban alone, aspirin, and of course, here is the primary outcome showing improvement from the combination therapy. And here you can see the effect on the limb. Now, the COMPASS study is a lot to answer for because it dumped carotid disease into PAD for some ridiculous reason. And in fact, that is PAD and that is carotid disease. And you can see combination of MACE and MAYO, this is a better combination. And this has led to the guidelines suggesting that this combined therapy, which attacks the residual risk of thrombosis along with the antiplatelet effect, is useful. Now, why is this important to you as cardiologists? I hope some of you will become vascular physicians, but if you're not, it's still important because the outcome of your patients who have coronary disease and PAD is very poor. Here's CABG, here's angioplasty, and you can see the outcome is really not very good if you have PAD. Same thing being shown, but also you note for asymptomatic patients, patients who just have a low ABI and who don't claudicate, possibly because they get angina beforehand. And also the outcome after MI is worse for these patients, again probably linked to the burden of atheroma. Finally, one last bit of peripheral arterial disease, the pudendal vessels coming off, the femoral vessels, erectile dysfunction. This is what Jackson said in 2006, and it's absolutely true. About 50% of men over the age of 65 have some form of erectile dysfunction. It's an independent risk factor for cardiovascular disease, and studies have shown that if you present with erectile dysfunction, after about 3 years, you actually will have had a myocardial infarction. So those of you doing risk factor clinics, folk who have not had a myocardial infarction or those with angina, this is a big warning sign for you. And the big problem is that people don't ask. And I would ask you in yourselves, do you actually ask your patients at your clinic? And if you don't, you really should. Here's the recommendation from the Society of Sexual Medicine, and it really is something that's very important because A, you can treat it, and B, it is a marker for a future event, and you need to be very aggressive in managing risk. So finally, ladies and gentlemen, this is a BMJ paper from 1987, which was called How to Treat Claudication in 5 Words, Stop Smoking and Keep Walking. And this was written by my good friend Ed Housley, who managed to set back the study of peripheral arterial disease by at least 50 years. And I remember a Department of Health person quoting this paper to me and saying that anything under a total cholesterol of 8 shouldn't be treated. And unfortunately, it has taken quite a bit of time for us to get with the cardiologist in terms of risk factor management. And therefore, it's a great pleasure to be able to tell you today that look for PAD in your patients and treat them really aggressively. Thank you very much.